COVID-19 has taken a tremendous toll on our communities and healthcare system, but has disproportionately affected the elderly. The Coronavirus Commission for Safety and Quality in Nursing Homes reported that the nursing homes are disproportionately affected by COVID-19, with data recorded through August showing 8% of cases and 41% of deaths in the United States have occurred among residents and staff. Moreover, patients with lower socioeconomic status or from poor neighborhoods have been disproportionately affected by this pandemic. Our group A4 was tasked with devising a plan to cohort residents according to their COVID status. According to a Doctors Without Borders briefing paper on responding to the crisis in nursing homes, quote, "There is no one-size-fits-all approach to cohorting that will provide an instant solution and ensure zero virus spread," end quote. A solution will entail a nuanced strategy that incorporates the facility's infection prevention protocol, structural capacity, and individualized approach to residents. Our goal today is to share our CARES intervention strategy with you all at Maplewood Manor to 1. Help mitigate and prevent future COVID-19 infection among your residents, 2. Ensure the protection of your staff, and 3. Educate both groups on these strategies to promote their health and well-being.
Specifically, we know that Maplewood Manor is a 5-story, 350-bed nursing facility currently at 93% capacity with up to 200 additional staff. We recognize that certain staff populations, including nurses and aides, are at increased risk for transmission, and that staff shortages have been an issue, given that many are more than 55 years of age themselves. Despite many efforts to decrease transmission, a significant proportion of your patients and support staff have tested positive for COVID. In an effort to consolidate and organize current protocols, we have devised the CARES intervention strategy, which encompasses contact tracing, airflow control, rotation of staff, education, and sequestration.
To start with the C of the CARES intervention, appropriate testing and contact tracing must continue. These data will provide accurate information for appropriate color-coded patient location, as well as to help assess staff safety and guide a rotating schedule. Weekly testing is also integral to mapping out transmission of the virus and moving patients to different zones as their infection status changes.
Next, to support testing, we will implement specific barriers to control airflow between resident wings. First, all floors will be separated at the middle with specific entrances, stairwells, and elevators for wings A and B versus C and D, used only by the corresponding residents and staff, effectively cutting exposure in half at baseline. Second, all COVID-positive wings will include an area prior to entrance surrounded by temporary plastic barriers that contains appropriate PPE. Lastly, COVID-positive or COVID-negative rooms may contain 2 people with no barrier protection. However, for residents who have been exposed and are awaiting test results, every effort will be made to keep these patients isolated in a room alone, or if space is limited, separated by plastic barriers.
Designating risk zones for patients and staff is an important method of limiting viral spread. These zones include red for COVID-positive patients, yellow for symptomatic, exposed, or recently admitted patients awaiting test results, and green for COVID-negative patients. To improve the safety and well-being of caregivers, we propose a staggered, rotating work schedule in which staff will move from green to yellow to red zones, followed by a 10-day break with pay. They will get tested for COVID near the end of this period, such that results come back before returning to work. This is an equitable system that will help conserve PPE and decrease viral transmission from caretakers to patients and vice versa by limiting spread from the community and the time working with COVID-positive patients.
In addition to preventing floor-to-floor contamination or cross-floor contamination by separating wing A and B from C and D, each floor can be sequestered in response to a rapid flux inpatient status. Using the building structure to our advantage and the probable path of infection spread as a guide, multiple permutations are possible with increasing levels of restriction moving from A and B to C and D if necessary. The ability to flexibly sequester residents within wings of the facility will be paramount in controlling infection. Most importantly, these concepts will require adequate staff and resident education, especially for specific patient populations such as those who are hard of hearing, visually impaired, or those with dementia.
We hope that these logistical changes for patient rooming and staff scheduling will build upon the weekly contact tracing in place by providing a defined framework for patient acuity, by taking advantage of the building structure, by decreasing resident and staff transmission via clear separation techniques, and by providing equitable scheduling practices for staff.
While both residents and staffs will need to buy in to these location and shift changes, We believe that clear education and expectations set upon implementation, color-coded signage and badges, consistent communication and management from the floor infection preventionists, and appropriate feedback from staff and residents will ensure successful mitigation of infection spread.